Hello, my name is Tom Ayres. I'm the Director of the National Collaborating Centre for Mental Health, and I'm really pleased to be hosting another creative conversation about suicide, latest in a series that we've been doing as part of the Royal College of Psychiatrists Patient Safety Committee. Today's conversation is going to be about suicide and risk assessment. So we've called it Suicide and a Risk Elephant. Before I introduce people, I'm going to ask Chloe Beale if you would please just introduce the topic, Chloe, that we're going to be talking about.
Yeah, so today we're talking about the language of suicide and risk, and this arose out of the fact that we know from research, and we've known for a long time about the sort of fallacy of risk prediction and risk quantification and the use of risk assessment tools as a kind of a standalone item. Yet still in mental health services, we have a real culture of using certain stock phrases, of quantifying risk, of saying things which we use to try and predict somebody's risk of suicide, despite there being no evidence for them. And I'm really interested in culture change in mental health. And so this conversation is really about why we say the things that we say about suicide risk, what that really says about us as clinicians, how that feels to be on the receiving end of some of the things that we say, and how we can effect change and make conversations between clinicians and patients about suicide more open and honest and ultimately therapeutic.
Thank you, Chloe. So the way that we are going to approach that today is we're going to have a conversation for about an hour. I'll let the people involved in that conversation introduce themselves in a moment. We'll have a conversation for about an hour about what I think is a really central subject in mental health services and in mental health and in suicide prevention and in people's lives. It's obviously a subject where it's a difficult subject to talk about. It's a difficult subject to listen to people talking about, and we will all have our own experiences. The people who are having the conversation, the people watching, will all have our own experiences of this. We will be trying to model and have as open and as honest and as transparent a conversation as we can, and we hope that that is something that is appreciated, and the way that people view it is in that spirit. I'm going to ask the other participants in the conversation, well, all of them actually, because Chloe didn't introduce herself there, I didn't ask her to. So I'll ask everyone to just introduce themselves for a second before we get into the conversation. So perhaps we could start with Becky.
Yeah, so hi, my name is Becky Cunningham. I'm a dual trainee in general adult psychiatry and medical psychotherapy in the West Midlands, ST4. I'm also a peer support doctor on the psychiatrist support service. And as part of that, I got involved in the working group of the effect of suicide and homicide on psychiatrists. So it's something that's really kind of relevant to our work in the PSS, and something that I feel quite is very important to have this conversation.
Thank you, Becky. Izzy?
Hi, yeah, I'm Izzy, and I'm a fourth year medical student at Nottingham Medical School. But when I do undertake my psychiatry placement, that will be at Derbyshire Foundation Trust. So I'm currently 22, so I've got a year left, and then I graduate as a doctor, hopefully.
Thank you, Izzy. Chiara?
Hi, so I'm an ST2 academic clinical fellow based in the Wessex Deanery. I have worked for various support services in and around mental health for many years, kind of on the periphery of medicine before entering medicine to become a doctor myself. And I'm a co-founder of a support network called Tea and Empathy for all those working within the NHS. And it's wonderful to be invited to be part of this.
Thank you. Mary, next.
Hello everyone, I'm Mary. Home for me is Devon, and I bring to this conversation my own experiences of many years of suicidality and severe depression in the context of having worked as a GP and a care of the dying doctor before that, and excited to be part of a conversation where we can talk honestly about the limits of medicine for people who are in deep despair.
Thank you, Mary. And I'll come back to Chloe now.
Hi, I'm Chloe Beale. I'm a consultant liaison psychiatrist in Homerton University Hospital in East London. I'm also suicide prevention lead for East London NHS Foundation Trust. And I have recently joined the Effects of Suicide and Homicide on Psychiatrists working group and the Patient Safety Working Group and the Liaison Faculty Executive Committee. I do some work with suicide prevention charities, and very, very excited to be talking about this with a group of fantastic, interesting people today.
Yeah, and thank you, Chloe, for being the driving force and to bringing us all together to talk about this today and and to talk about this topic as well. And I think, as you said, as it has been with all of these conversations, a really interesting mixture of people and a mixture of experiences that everyone will bring. And I want to start maybe by thinking about our own experiences or your own experiences. As I said in the kind of brief intro that I did, we all have our own experiences in different ways of this subject. So I wanted to kind of start by asking you all kind of how your experiences have affected the way that you talk about suicide and risk, and what differences they may have made to your approach to a conversation, how you may have a conversation or how you do have conversations with people who are suicidal. I wonder if I could start by maybe going to Izzy with that question.
Yeah, so my experience is quite unique compared to the other doctors on this group, in that my training's been quite interrupted by the thing we like to call COVID, in that I haven't yet had my psychiatry attachment in person. I've had it online, but I haven't yet been able to put my skills into practice because of COVID and all the social distancing things that happened. So I've been able to learn some stuff online, but now that I've gone on to the wards, my experiences have been quite different to what might be expected of a normal medical student, because with social distancing, if we see a registrar on the ward, everyone latches onto them. It's quite funny. And it's, my experience is very make the most of what I get. And so even though I haven't done my psychiatry attachment yet, I have done my community-based medicine, so GP, and I've done my paediatrics about starves and gynae. And in both paediatrics and community-based medicine, you do get acute psychiatry presentations. And I do watch the junior doctors, the registrars and the consultants all, deal with these sometimes, acutely suicidal patients, which can be really upsetting to see, especially when they're age 11, and seeing how they interact with them, how they deal with these conversations. And even though we have had this online teaching, it's so clear to see that, nothing compares to in-person, on the ward-based teaching. And I will copy what these people do, whether it's a junior doctor, a consultant. I'm more likely to take that into account, and next time I do it myself, it's like see one, do one, teach one, isn't it? I'll probably take that into account and do it myself. So med students like me are very easily influenced by my elders, and so it doesn't matter what I'm taught, and I have been taught some amazing stuff, and I'll always, bear that in mind. So I do have the background knowledge, but I'll probably copy you on the wards. And so it shows the importance of always updating your knowledge and continual learning and challenging yourself and your preconceptions, and talks like this kind of enable that to happen, I think. And that's why this is so important, and to be able to see that, for people like me who maybe haven't had that much experience for me, it's really useful to learn about, how I might go about talking about it when it comes to me going into my psychiatry attachment in a few weeks' time, how I might go about talking to someone who's at risk of suicide or potentially at risk of suicide, and going about that in the best way possible.
So is it kind of thrown into the system of being a medical student and learning? I think what you're saying is the biggest influences are the people that you see doing it. So the junior doctors, consultants, registrars. I wonder if does that reflect other people's experience, or in fact, as more senior doctors, are you acutely aware that that's what's happening when you have medical students with you?
So I suppose I can echo some of that, in that I'm the next level up in the hierarchy, so to speak. And I think that it's one thing to be taught the technicalities and the flowcharts and the processes, but that's not often representative at all of a patient's experience, of their life, of the narrative of their experiences. I'm in many ways very lucky that I entered medicine a little bit later, and so I had experiences of working on support services before entering medicine, and learning to just be with someone and to hear their story for what it is immensely powerful. But that isn't what is taught within the frameworks of medicine because of many reasons, but also time constraints. We're expected to absorb a vast amount of knowledge to be able to sort of have an appreciation of so many different systems, the body and us as animals, as complex beings, psychologically, physically, it's all interwoven. And then we're put into environments where there's sort of almost a war zone mentality with this toxic positivity of, be resilient and keep going. And there's little space to use that skilled intuition or to just hold presence with someone. And that comes with, I think, experimenting, I think time. I've been very conscious to try and hold on to that because I came into medicine with it, and to not lose it. And I don't think it's something that is taught at the moment within medicine very easily. I think the systems around healthcare, it's hard to teach that sense of, I think in DBT it's referred to as radical genuineness, the ability of just being there. And I think that's key in this discussion.
I completely echo some of those points. And when you asked that question initially, Tom, there were kind of two things that came to my mind. The first was my very first induction as an F1, and having a talk from the coroner, and it really it was very unhelpful. It put the fear into me, and that's really stayed with me throughout my training. And in a way, I've been lucky that I haven't had I haven't really had any direct contact with a patient who's ended their life by suicide, but that fear or that anxiety almost grows because that thing still stays with me. And the other thing that came to my mind was in our psychiatry training, right from the beginning, we had weekly CASC training where we would have a kind of a simulated scenario, as everyone listening to this podcast probably knows. But you have a checklist, a mental checklist of questions that you ask, and risk assessment comes up in most CASC scenarios. And I think you almost, in a way, it's very good to have this practice, but it becomes so ingrained in you, you can almost kind of reel this checklist off in your sleep. And then that takes away from that relational aspect of psychiatry, because it makes it seem quite detached, and that's your agenda. So you then kind of exploit that into kind of real life situations where the agenda is almost kind of yours, because you're just making sure that you kind of get through that checklist.
I think it's really interesting to hear what the sort of trainees in the group are saying, because that certainly echoes what I sort of feel and suspect goes on as a consultant. I think that, my, the experience that I bring is predominantly my clinical experience, and awareness of how important it is to have a human approach in consultations. And I'm interested in people. That's why I'm a psychiatrist. I like to hear and build a narrative of somebody's life. I like to build a picture of what that person is like. And you can't do that with a checklist or a pro forma. And I remember the first time, a sort of key moment of becoming interested in this was when I first heard Nav Kapoor speak actually about the fallacy of risk assessment checklists. And it was just such a relief to have it confirmed that, this suspicion, these things that I'd always disliked as a trainee, I was kind of right to dislike them because they weren't evidenced. And I remember even as a medical student, I was really frustrated with the way that we were taught to make empathic statements, which you often saw being parroted without any actual empathy. And I've always encouraged my own students and trainees to listen to their human instinct, because you probably wouldn't say to a friend or relative who is in crisis or in distress, I can see that must be very distressing for you, while staring at the floor. And I find this extraordinary. Like every medical student, OSCE and postgraduate exams as well, you see candidates coming through talking about things being very distressing. Who says that in real life? This is something that we learn. I don't know, maybe people do say it in real life. It just feels really clunky and unnatural to me, but this is clearly something that people are being taught. Like medical students are taught to say things like, this is just a screening question, or this is just a question I have to ask everybody, which surely must translate when you're on the receiving end of that to, I'm not thinking about you specifically, and I really want to move on from this quickly, and this question makes me uncomfortable. And I think that that's what has come to really drive my interest and my approach in this area, is that I think that, it's very clear that we all bring baggage as clinicians, and perhaps we've lost a patient to suicide, or we've heard horror stories about clinicians being blamed, or we've had a terrifying talk from a coroner, as Becky said, or we're simply understandably terrified that someone will end their lives and we weren't able to stop them. But what we're taught to do is to deal with that by seeking reassurance from the patient, and to ask them to guarantee their safety or call a crisis line if they're feeling suicidal. And in that way, we falsely reassure ourselves. So lots of the language that we've built up in mental health has nothing to do with the patient or supporting the patient. It's about reassuring ourselves and treating our own anxiety, and trying to kid ourselves that we can reliably predict that somebody is low, medium, or high risk. And I think that I've always been quite a straight talking person, so I'm probably not that scared of asking difficult questions, which I think is probably key. And, it's not for me to say whether I'm a good clinician or not. I don't know, but I think that as long as we're scared of the answers that our patients might give us, we're always going to struggle to approach the subject of suicide openly. And actually, I don't have sort of extensive experience, but my own experience as a patient kind of lends weight to this as well, because I remember being asked about suicide, and the anxiety of the clinician asking is palpable, and the desire that you get from the clinician that you will say no and not put them in a difficult position where they have to do something is really evident. And I found that incredibly striking, and such a contrast to being in a clinical situation where the clinician feels like they are containing you and you can say anything and it's going to be okay and you don't have to reassure them. That I find a really sort of striking difference. So these are all things that have led to my own approach to suicide and risk.
I wonder if I can come in there, because as a person who has had quite a lot of experience of being on the receiving end of these sorts of assessments, I echo so much of what other people have said. Firstly, in relation to what Chloe just said about reassurance, I think that I quite often found myself knowing that the name of the game was to reassure the clinician that they were clearly worried or anxious or frightened, and the most I could offer would be to make them feel a tiny bit better if I couldn't make myself feel better. So I think that is profoundly important. I think the other difficult thing is that we are, as people, not as doctors, not as clinicians, just as people, trying to help and support and be kind to each other, often driven to do something. And the great difficulty about this is it's a being thing. You just want to be with someone. A good friend of mine who's a Buddhist chaplain says, Mary, you have to remember that we're called human beings, not human doings, for a reason. And actually a checklist, a risk assessment is all part of a sort of pointless doing. So that's one perspective that I think we all share. The other that other people haven't yet mentioned, I think for people like me who found themselves in this position quite often, behaving in ways that were life-threatening or dangerous or chronically harmful to myself, I knew that if I answered some of those questions in a certain way, I lost what was most precious, privacy and freedom. And when you acquire a fear of being sectioned again and again, when you think your children might be on an at-risk register, when you think something terrible will happen, the whole name of the game is to try not to tell the truth. And almost for me, one of the most painful things about these sorts of assessments is finding yourself challenged in your identity. If you think of yourself as quite a truthful and straightforward person, knowing that actually you're being at best economical with the truth in response to some of those questions is just another painful part of this reality. So I think we've all got very similar views about the falsehood that risk assessment creates and what an unpleasant and unreal situation that is.
Yeah, it's interesting that from I think different sides, I think people have talked about, the feeling that clinicians don't want to get into that conversation. It makes because they're anxious, that they feel they need to do something, they don't perhaps feel powerless. But also, Mary, you were talking about, and this certainly I've had lots of conversations that were from people that would back this up, or who would say similar, is that actually often patients don't want to get into that conversation because of the, let's say the name of the game is not to have your freedom taken away. I was also really intrigued by your phrase, Chiara, of toxic positivity. And I wondered if you might be able to just kind of expand on that a little bit, on that idea.
Yeah, sure. I think we are very good, particularly as clinicians, we're trained to hold anxiety. We are often working in amazing multidisciplinary teams where we sort of are a part of a system that isn't always, in many ways, at all perfect. And there's a degree of, I think we'll address this slightly later as well, but a risk of blame shifting and of pushing the responsibility in every other direction but ourselves. And that can be pushing responsibility towards a patient. It can be pushing responsibility towards peers or towards seniors, but there's this sense that loses something on the way. And I think with toxic positivity, it's rife at the moment with COVID. So many of our colleagues really struggling, and this sense of just keep going. It's going to be fine. We'll make do and mend. And there's a line there. There's a limit to that, and it's often the power of the language that we use. Just as we are educated to speak English or whichever native language we have, we start off with that, and that brings with it its own cultural assumptions, its own patterns, its own idioms. And then we do the same within healthcare, that we have specialist language that defines us as in the tribe or out of the tribe, as to whether you understand the words that we're using and the terminology. And I think there is a danger of exclusion in that. And by the same token, we do the same thing to each other and to ourselves, that there's this warfare culture, and that medicine is often a really harsh place. I think at every level of whatever hierarchy you're looking at, I think it can be a place that is driven by time constraints, intensity, targets, systems, risk assessments, performers, flowcharts. And it doesn't always leave a lot of space for the thing that suddenly brought me into medicine, which is the human connection. I suppose that's a very roundabout way of explaining my understanding of this positivity sense, that it's more of a not a true positivity that's sort of born from the soul. It's a desperate positivity, and that itself is harmful not only to the person holding it, but also to the system. I'd be very interested what other people think, but that's my sense.
I think I'd add to that, like, as a student especially, you see it all the time over social media and things, people, you know, posting things like, oh, we'll get through this, especially with COVID. And, you know, will we? You know, it can get very to the point where, you know, when we were first in March, when it was all very surreal. We were all sent home from university. Everything stopped so quickly. And, you know, all these rainbows started appearing, and there was a clap for the NHS. And at the time, it all seemed so like a novelty. Like everything was actually quite positive, even though the world was collapsing around us. Like it actually seemed like everyone was like, there's a bit of a blitz spirit about it. Like everyone actually seemed quite positive. But suddenly, you know, 10 weeks later, everyone just burnt out suddenly, I noticed. And I think that's the same sort of thing you're describing, that you can keep going, but it's very short term with this sort of the positivity, and eventually it will come back and have an effect on you as well. And it's not going to be very long lasting if you're using that as a way to almost protect yourself from the, you know, what it actually is, if you're not going to face it for what it is. Eventually it will come back and maybe get you even worse than it would have before, if you hadn't, you know, had a real good think about what does it actually mean for you in the first place. I'm not a good way of describing it, but it does show the it's quite a good analogy, like with COVID, the peaks and troughs, especially with the eat out to help out. That was another one. It all seemed quite good, and then it's all quite positive, and then suddenly it all kind of fell to pieces again. And you can see the disappointment and everything, and it just, everything seems positive and suddenly it's not, and you have to deal with the consequences. And I think that's a good way of just showing that maybe just looking at it a little bit closely to start with might be a good idea.
Yeah. So avoiding the difficulty,
yeah,
the difficulty of the conversation doesn't really help anyone. I suppose is the. So Chiara,
I had one more thought that just kind of sprung to my head as I was hearing that from Izzy. That toxic positivity is also something we displace onto others. And I think in our risk assessment, and perhaps Mary would have more to say on this than I would, but this sense that we are not only wanting a patient to tell us that it's going to be okay, but also conveying this, you know, but let's just be positive here. and that's not sitting with a person where they're at. You know, you might not be able to be alongside someone in their distress necessarily, because thankfully you might not be in that place, hopefully, as to where the patient is emotionally, but it's that physicality of sitting beside each other and walking beside each other, and that understanding of, you are in this place right now and you might not have hope right now, but let me take that hope for you for a little while and then I'll pass it back. And that's not a toxic positivity thing. That's a walking alongside. And I think it's very easy to blur that line. Yeah. Perhaps Chloe or Mary, you would add to that.
Well, I think my experience of what perhaps you mean, Chiara, by toxic positivity is actually how it feels, because it is when you don't really mean that, or you'd be dead by now, or stop saying that, you've been saying that for years. All of those things actually just trivialize the sort of suffering that you had. You wouldn't say to somebody with leukemia, don't be ridiculous, don't make such a fuss, you haven't got any neutrophils. It's not that bad. And yet this sort of positivity, let's find the silver lining in this cloud for you, as if you haven't tried and searched in every way that you can think of to find your own grains, tiny grains of positivity. So I think at the receiving end, it feels as if it diminishes you somehow as a person. And so I think it's a very helpful notion to recognize that actually it has the potential to do harm. At a very simple level, it is a harmful to the person sort of a behavior, really.
I think one of the things that's been most influential in my practice has been working with third sector organisations, and specifically a charity called The Listening Place, because I think that what is so striking that's different from working in the NHS is you see what happens when people are having an open and honest conversation with someone who's suicidal, when they don't carry the same baggage that we do as clinicians, when the person offering the help isn't fearing blame or feeling the need to be reassured. And what you see from feedback from those kinds of organizations for people who have benefited from that support, time and time again, it's kindness, it's somebody listened to me, someone didn't try to belittle what I was saying. And I think that's a really interesting thing actually on the flip side, but no more helpful to what Mary was saying about the fear of being detained, is that you'll have lots of people who will tell you how they feel that they have to recite a certain script or emphasize certain symptoms in order to be taken seriously, in order to be offered a hospital admission. So you're damned if you do and you're damned if you don't, if you're trying to get help in this system, because if people think that you're too sick, then you're going to get detained and your freedom taken away from you. If people think that you're not sick enough, then you're a time waster and you're not deserving of our precious hospital beds. So people learn, I think, to speak the language, and how that can be helpful, I don't know. And, I do lots of work with, people with lived experience where I work, and what I hear in feedback time again is, unsurprisingly, people who access services and people who have experience of being in suicidal crisis know when a clinician is going through a checklist in their head. They know when they're being expected to say certain things. It's like a game of, psychiatrist bingo, that you tick off, oh yes, the attempt, or whatever happened, the self-harm was impulsive, and no, you don't have a plan, and yes, you can guarantee your safety, or you can't guarantee your safety. I mean, these are all terms with absolutely no evidence for anything. And I think from what I hear from people is it's immensely frustrating being on the receiving end of that. And if you ever hear from anybody who's been in suicidal crisis, people generally talk about the thing that made the difference being kindness, listening, sitting in the moment, holding hope, not trying to change things. I've never in my career heard anybody say, my life was saved by a really thorough risk assessment.
Let's talk about risk assessment, which I think we're obviously already started to, but I know, Chloe, you said it talks about hearing Nav Kapoor talk about the fallacy of prediction and risk assessment, and I've heard Nav talk about that several times, and I sort of feel like this should be really liberating for the system. It should be really liberating to hear this from a world expert, from NKish, one of the most respected centres in the world on suicide and self-harm, and their professors saying this very clearly again and again. It should be liberating to the system. So given that we know that, and lots of individuals in the system know that risk assessment is fallacy, why do you think we continue to do it in the same way, largely? Why do you think we continue to use or to pretend that risk is measurable with a scale or quantifiable in the way that we do? I'll perhaps start with Mary with that question.
I know everybody else is going to be talking about You know, the paperwork, the public conception, the coroner, all sorts of really terrible negative influences that make professionals fearful in these contexts. But I think this is really about fear at its very heart, and those things play into it. But I was thinking about the comparison between efforts to save lives in other medical emergencies, that if somebody has a heart attack or is involved in a road traffic accident, people take all sorts of heroic steps to save lives, and can, even should somebody die, say, we tried our best. We did everything we possibly could to prevent this person dying. It's a tragedy, but we did our best. And they can evidence that, and should they find themselves in a coroner's court, they have a story to tell. They can tell themselves it, but they can tell it publicly and probably not be found wanting. And I think the contrast between that and somebody who challenges the whole notion of humanity and survival and what it is to be a person by telling you that they want to take their own life strikes at the very core of ourselves, but doesn't have any of the same consolation. So when Becky was saying earlier about the need to recognize that mental health is not a science, that there isn't a biological or scientific or same sort of rigorous evidence base behind anything, and all you're left with is the simplicity of being yourself, authentically, simply, kindly being yourself. That feels like nothing, but it's actually the most important thing you can do, because you can show someone that even if their life doesn't matter to them, it matters to you caring for them. But sadly, that doesn't stand up in the public press or in court. And I think, to answer your question about when eminent people like Nev say publicly that there is no evidence, when many people working in mental health care services know that, why it is that public understanding has lagged so terribly far behind. And that may actually connect with something around a much more widespread citizenship of fear, that people are frightened of things they don't understand. And mental unwellness is one of the things that people don't understand. And so the whole game of make-believe around risk assessment plays into that much more societal issue, and the stigma surrounding mental health illness more generally. And it would be a brave effort, but a concerted effort, to challenge that in society much more widely, because until that happens, psychiatrists will still be hung out to dry for the checklist they didn't complete, which is a tragedy, really.
Just following on from that, I mean, not only do we know that risk assessments don't work and aren't predictive, we know that from other kind of studies in psychotherapy, that actually the most important thing in terms of outcomes is the relationship. So when we know those two things, it seems ludicrous that we're kind of clinging on to these checklists. And I think we need to start asking ourselves, why aren't we changing?
I think that's driven by fear more than anything. We have this sense of defensible and defensive practice, that actually there are certain things we have to do, and we have to show that we have done everything and prove that we have ticked all the boxes, even though those boxes may not be in the best interest of the patient. But as I think Mary said, and Chloe said, and Becky said, it doesn't necessarily stand up in court. And so we're trained to follow those checklists because of these pressures to be safeguarded by a system. But what that then falls into is defensive practice that's not necessarily putting the patient at the heart of what we do. I suppose I also wonder around power, something about power, and something about not only the challenge to our own selves of someone who is considering injuring themselves to the point of ending their life. That's significant, and that hits very deep to the core of who we are as human beings. But also as I mentioned earlier, this sense of being part of a tribe and defining self and other, and the language we use that creates boundaries innately, consciously, unconsciously, creates divisions. And so by doing all these risk assessments, you know, it kind of alleviates our fears a little bit more. And it's like, well, the boxes are done, but also we have this risk assessment that's often not openly shared, that may even stretch to the point of being dismissive of a patient's distress, as Mary said, of sort of saying, oh, well, you know, they're saying this, but do we actually believe it? And in that, we're not with the patient, we are in our own tribe. We're doing our own paperwork and we're doing our own thing, creating a boundary. And I think it's on so many levels. It's a system, it's regulation, it's government, it's process, it's financial, it's you know, the societal expectations and perspectives on mental health, as Mary alluded to. It's so multi-layered and complex, but it comes down to fear. It comes down to fear, and we're trained, you know, that fear is passed on. As Izzy was saying, it's hereditary fear in the hierarchy of medicine.
Yeah, I think that we, you know, it goes right back to bad habits that we learn in training, and, you know, not just doctors, nurses, other health professionals. And then as juniors, we see things written in notes and we hear certain terminology and we pick it up ourselves. And there is absolutely 100% agree that what's at the heart of all of this sort of defensive practice is fear. You know, and I think that I don't think that inquest or serious incident review processes help either, because you see people sort of really seem to be under pressure to say, with the benefit of hindsight, that they would have done things differently. And I think that we feel that the only acceptable excuse for having got it wrong or failed to predict what someone was going to do is that we predicted low risk and they didn't do what we thought they were going to do. I think it feels totally unacceptable for us to say, well, yes, there is risk. You know, I'm not going to pretend there isn't risk. This is what the risk is. This is what I think is going on. And this is what I think that together we can do to manage that and mitigate it. And I think that, you know, you don't sort of see oncologists claiming that, you know, you're going to cure everybody and there's no acceptable way, you know, there's no acceptable way forward other than to pretend that with every patient you can reliably predict, you know, the prognosis of their cancer. And so everything comes down to being our own fear. But I really think that organizations, you know, what we do, I think that serious incident review processes and inquests get it wrong. They ask the wrong questions. They focus in on individual human factors. And yeah, of course, sometimes people get things wrong, but I think in the vast majority of cases, you cannot point to a person or a factor and say, if that person had done something differently, that person wouldn't have ended their lives. I think that's unrealistic. And of course, things go wrong. And of course, we should learn from them. But I think we zero in on individual human factors, and we don't look at the, you know, systemic factors. We don't comment on the system that's going on. And, you know, you never, I don't think, you know, not in my experience, and possibly if there's something more obvious, but you don't seem to tend to have, you know, chief executives or medical directors being asked to give evidence in an inquest or speak to a serious incident review about why, you know, why you have X number of beds, or why, you know, this is the home treatment team's inclusion criteria or whatever. So I think that individual clinicians are being expected to make excuses for organizational and systemic factors. And in that, all you can do is do magical thinking and pretend that you can predict risk, because you're not working in a culture that embraces honest conversations and you know, openness, and it doesn't allow us to say things like, well, you know, actually, this is really difficult to predict and to prevent. You know, it's in every training program, it's in all of our protocols. And then I think well-meant initiatives, which tell us that we have the power to prevent all suicides and that every suicide is avoidable. You know, I think that's quite a controversial thing to say, particularly to people who have lost someone to suicide, who understandably, you know, often can't contemplate the idea of a suicide being unavoidable or unpredictable. But I think that sort of idea that the only acceptable thing to aim towards is a complete elimination of all suicides doesn't actually help the people that we're trying to help, because it reduces everything to numbers. And we're just thinking about what we could do, you know, from the outset, from every consultation with a suicidal patient. Our starting point is, what can we do to stop this person dying? Or at least, what can I do to prove that we couldn't have stopped it if they do die? And instead, our starting point should be, who is this person, what's going on from them, and what do they need? So I think that we keep doing it because we don't operate in a sort of culture and in organizations which are permissible of using the evidence. And I think that's really sad and really damning. You know, I don't know if there are other medical specialties where there is such a glaring example of constantly going against a certain piece of evidence.
Yeah, I'm trying to think of one. I often try and think of that. I'm not able to. Izzy, I'm wondering how it feels for you to be kind of listening to this conversation really right at the start of your career.
Nothing's changed. I mean, I was going through my online, like the resources we're given, and the first piece of teaching that we're given is the mental state examination, and say, learn this, you need to know this off by heart. Well, you can have a resource, but you need to know this is how you assess someone who might be acutely suicidal or at risk. But it does say, we are aware suicide shouldn't be a tick box exercise, it's much more than that, but this is how you'll have to assess it in an acute scenario to avoid missing something crucial. And that's how it is. And it's a shame, because you're right, it shouldn't be a tick box exercise. It's so much more than that. Like, there's the whole biopsychosocial model, isn't there? There's so much more going on than just in the moment, like, in the last hour, like, what the patient's actually been going through, what's actually the patient's done. Like it could be something that happened a year ago that they've suddenly has become really, they've been reminded of suddenly, and that might be causing it, but that's not going to be brought up in the mental state examination necessarily. And I think that it's things like that maybe a revision of it or something along those lines, but it's, where do you get the funds needed, the reviews needed, everything needed to be able to do that? But it's something for the future to really bear in mind, and have I guess my generation to go into and think, what can we do about it if this is a real issue? So
I guess that's where it'd be good to move the conversation on to, really. So we've talked about fear and a bit about blame, but I think one of the things about the fear in this instance is it's often quite well grounded fear. The repercussions do happen. But how do you think we can move from that position of fear and all the things that come from that you talked about, to a place where people are having and feel able to have more honest and open and therapeutic conversations? I wonder, maybe Becky, if you could start us off on this one.
Yeah, I mean, I guess we've already covered some of the punitive and kind of blaming mechanisms that happen following a suicide, but I guess we need to change the education system as well, because like Izzy said, you learn what you're taught and then you repeat what you're taught. So we need to really kind of focus education at a very early level, because I think once you've learned something, it's really difficult to then unlearn it. So if we can target this at the level of kind of medical students and then foster it all the way through, right up until kind of a more senior level, then that's how we're going to kind of change future psychiatrists, really. And I think we need to shift the balance back to the art and the creativity of psychiatry, and not just focus on the objective scientific part, because psychiatry is unique, from other areas of medicine, and we really need to kind of foster those relationships. And I don't think you can't prescribe these stock phrases. You can't prescribe how to have these conversations. It's about experiencing them and getting out there and speaking to people and having these open and honest conversations, I think, rather than just having these kind of lists and lists. And yeah, we need to stop replacing humans by algorithms, I think.
I want to come back to the idea of science. So a few people have mentioned science, or the science. We're pretending that there's a science to risk prediction and so on. And I find it really interesting. I'm slightly going to be maybe heretic as an employee of the Royal College of Psychiatrists, but the idea that science equals objectivity, I think, is interesting. It's a pretty dominant idea in our society, but the scientific method that we all know is really only a scientific method. There are other scientific methods, and critical analysis is a valid scientific method, and understanding your own subjective place in a conversation or a subject is a scientific. That is science. It's a different philosophy of science. It's not the one we're taught at school necessarily, but it is science, and perhaps also art. But I find it interesting that the idea that science is only valid if we can objectively observe something is such a dominant idea. But I think it's not. There are other interpretations of science and how we interpret things equally as scientific. And the other thing, sorry, before I just go on to listen to other people, but is when Izzy was talking about, and both of you talking about, starting with medical students and it carrying through, and I suppose I felt some hope when you were talking about that, because I felt like actually there is generational change in practice and culture, and I think I've been working in mental health services for about 16, 17 years, so not that long, but a while, and there's a different culture now to what there was then, and the dominant voices that I hear talking about mental health now are different, generationally different to the ones that I heard kind of even just 15 years ago. So I think there is kind of that hope in the passage of time and new generations coming through. But I will stop speaking now and see if anyone else wants to talk about this sort of question about how we move forward. Sorry, Izzy, I think you want to come in again.
What I'd say there is that also over time is that I've noticed, like definitely from secondary school, so from when I was 11, is the change in the terms that we use to describe mental health, and terms around suicide have changed and become less appropriate to use, and the stigmatization around certain terms has changed. So things like, oh, you're not going to go and do something silly, are you? Like that would be seen as not appropriate to say in a GP consultation or in a hospital appointment. I don't think that would be seen as something that I think I'd probably fail an OSCE if I said that, because I think it's to say that to a patient, like for them it might not seem silly, it might seem the only option to say, oh, you're going to do something silly, because that kind of belittles their feelings a little bit, when for them it's genuinely real what they're feeling, and what they're feeling is, and again, people might say, oh, you're not going to do something stupid. For them it might not seem stupid, it might seem genuinely the right thing to do, because for them that is the right option. And so terms like that have been changing, and of course there's the use of words like like the use of common mental illnesses to describe, general common moods has become less and less common. I've used the word common 3 times in a sentence there, but but like when people say things like, oh, I felt so depressed yesterday, when really they're meaning they just felt a bit sad. I mean, did you feel depressed, or were you just sad? Things using mental health diagnoses to describe typical emotions has become less and less, well, more and more looked down upon. So I think times are changing, and that's only in 10 years. So hopefully within a few more years, a bit more can be done around that. And I think that it does make it a little bit more open, that when people do discuss mental illness and things like that with a professional, it does mean that actually, if they are going to talk about these things, that it's probably going to be more honest, because they are actually bringing these terms up in ways that mean something, as opposed to just colloquial terms on the side, which is important, if you ask me. So I think that's a good change I've noticed. But as I said, I don't have much experience to say. I mean, I've only had 4 years at medical school. I can't talk from a big perspective of change, but I mean, that's just little things I've noticed.
Yeah, that's really interesting. Thank you.
When you were saying, Tom, about the scientific divide, almost the emotional scientific divide of the mind versus the body, and I think so much of this stems from the history of our profession and the history of science and the history of our field, that logic was viewed as the male domain and the powerful domain, and the right stuff and anything emotional was equated to needlepoint and tea cakes. And it was this very I think our heritage is based around an arbitrary divide in emotions versus science, and we are more and more learning that they are interwoven and integral, and we're learning how the brain works, and we're learning year on year further and further delving into essentially the unknown realm of the human mind. And that makes this field both immensely exciting, but also quite a vulnerable field to work within, because there's so much change and so much evolution, rightfully so. And we, from what you were saying about kind of the place of data, I think these performers and these risk assessments, and whether something is evidence-based, if we're taught it, we assume it has evidence, and we assume that quantitative data is somehow the best and somehow powerful. We are taught that comes first, that emotions are unpredictable and volatile, that they can't be understood necessarily, because of a heritage in our field and a heritage of our understanding of our emotional worlds. That's hundreds of years of societal influence in that. And I think it does come down to education. As I think Becky said earlier, the shifting of the blame culture on every level, in every system within this kind of work, understanding the emotion of language and the language of emotion to a deeper extent. And I think particularly for medical students, speaking to what Izzy was saying, teaching vulnerability. I think we are trained as medics to be perceived as somehow invulnerable. We don't, physician heal by self. The kind of invincible 24-hour plus shifts that used to be worked. There's a cultural heritage there too, that actually medical schools don't tend to teach the grey spaces. It's increasing, but things like arts, narrative medicine, teaching that, yes, you might have a flowchart, but actually some of your patients won't fit your flowchart. With the best will in the world, you will not be able to crowbar them in. If your patient does not want to take a tablet, maybe prescribing it is redundant. These kind of discussions that aren't really mentioned. It's like, oh, well, they have high blood pressure, therefore prescribe a tablet. And I think that those that culture is changing. It is changing, but it's slow, and it requires all of us to challenge those at the higher end and the lower end of this hierarchy in MDTs in diverse ways, and the patients as well, to challenge us to say, I'm not going to take your tablet. I need you to talk to me about this, or this is actually what's important to me right now. And for most patients, that's again forcing responsibility onto a patient. But I think we're getting there. We are working hard to find a balance more and more. So I'm hopeful for the future of it. I really am.
Thank you. Mary, you were going to come in, I think, as well before.
I wanted to thank you for that interjection, Tom, about science, because actually I think that I certainly was speaking quite loosely about that, because when Becky was saying quite rightly that this whole business is about relationships, scientific method does allow you to understand the basis of genuinely therapeutic relationships. And that's really what we have been talking about, genuine therapeutic relationships. So I think one of the things to be hopeful for is that there can be growing credibility to the much more nuanced scientific understanding of the ways in which what you say and how you say it makes a difference to the person on the receiving end of that. So I think science is not the baddie in this story, really. I think we were misspeaking when we suggested that. But the second thing I wanted to say is that, picking up on what Chiara has said about putting on the patient, one of the fundamentals in these interactions with people who are thinking or at risk of ending their own lives is who owns the risk. And ultimately, I own my own risk. I will always own my own risk. And if you can help hold the hope, you can offer to help carry the risk. But ultimately, it will rest with me. It exists within me and around me. So I think this recognition that someone has the freedom to own their own risk is probably one of the fundamental truths that might shift the way in which people think around this whole area.
That's immensely powerful, Mary.
Thank you. Chloe, I think you were.
Yeah, I think that science and objectivity and compassion don't have to be mutually exclusive. I think it's possible to to follow the science in a kind and compassionate way. And I think that one of the things that helps in terms of sort of teaching and training and getting the message through about this is the evidence and this is what we should be doing is kind of working side by side to deliver training with people who have lived experience and doing that in a non-tokenistic way, in as equal a way as possible in a situation where there is always going to be a power imbalance. But I was sort of thinking back to, years ago, sort of in the much earlier part of my career when, you used to go to grand rounds and, in psychiatry or other aspects of medicine, and a patient, a sort of interesting specimen would be wheeled out in front of an audience and either like a sideshow exhibit, and either asked questions in psychiatry or had signs elicited for other aspects of medicine. I hated it. I could never stand it. I could see how it was interesting, but it just felt horrible and sort of exploitative and strange. And the contrast with when one delivers training in a truly co-produced way, and the impact and the power of hearing the words of people who will support what the science says, which is checklists don't work, the therapeutic relationship is the most important thing. So I think supporting what we know in terms of the evidence with real human stories, I think essentially is about rehumanizing medicine. And I think that we need a bi-directional approach. Like I've said, I think that there is hope for the future. I think that, some of the students and junior doctors that I interact with, you know, kind of give me hope. You know, psych socks didn't exist when I was at medical school, and now they're everywhere, and all these, you know, enthusiastic young people and students, you know, kind of throwing themselves into that world and wanting to learn more, and you know, is really encouraging, and wanting to have these conversations. But if we're not careful, the system will beat their humanity out of them, like it has done for, you know, other generations, and, you know, other mental health professionals, not just doctors. And I think that for a lot of junior doctors, and also for nurses and other health professionals, you know, might well feel that it's all right for, you know, us, you know, consultants and seniors and you know, researchers and professors to sit here sort of pontificating in our ivory towers. But actually, when you're on the front line, when you are the junior person, when you are, you know, the nurse on a ward or answering the phone or whatever, it's not so easy to sit there in the coroner's court and sort of say, well, you know, I was, you know, there's no evidence for this checklist, and actually I was showing a human approach. And people will say, well, but there is an expectation. And I think that what we can't do is be unrealistic. And you know, so I don't think it would be realistic to say, you know, we can dispense altogether with, you know, defensive note writing. You know, I certainly don't. I think my, you know, my note writing is sort of legendary for, you know, how expansive it is. But and it's fine to think, what if the worst happens? You know, that's okay to do that, but you just have to justify why you made that decision, or why you made that plan at that time, rather than feel that the only way of justifying a decision is because you thought the risk was low and you predicted something which then, you know, went on to not happen. So I think that, you know, I'm not suggesting that people, you know, sort of dispense with all of the things that they've ever been taught to write, and, you know, write, well, you know, I had a compassionate conversation with the patient and I was kind to them. But I think writing and focusing on aspects of that person that are personal to them and at that time, rather than writing heading risk, which is always treated as something separate to all the other bits of a clerking or an assessment. Heading risk, and people, you know, you put to self low, to others medium, vulnerability high, you know, whatever. Or writing sort of checklist, this person is at high risk because they're male, unemployed, uses alcohol, rather than, okay, well, that predicts, you know, the risk of a population, but that doesn't predict this individual's risk at this point in time. So actually, it's more about intelligent note writing and intelligent information gathering. So, you know, no, of course, no one's ever going to dispense with, you know, making it clear in notes why we did what we were doing, and writing in a way that could later be used to defend what we've done or defend the decisions we've made. But I don't think that it's either or. I don't think that it's, you know, pragmatism or compassion. I think that a good clinician can do both. But I think that, like I said earlier, there's no point just doing this at the level of individuals, of training, you know, people coming up through the profession to do things differently, because organizations need to have the guts to change the conversation and to implement meaningful training around suicide and risk, you know, because otherwise it just becomes a slightly altered tick box. You know, so actually we need to call upon the organizations that govern us as clinicians to have the guts to follow the evidence and to support us in delivering compassionate care. Otherwise it's all just lip service.
It sounds from what Chloe was saying, it's that idea of integration, you know, integrating these different approaches. And that's a challenge. That's a challenge to us all, because we might have been taught in certain ways, and it's certainly easier as a human being to have a black and white view of things. It's uncomfortable to sit in the middle ground and to hold different approaches at the same time and potentially do them imperfectly, but to try. And I suppose my instinct is that it's likely to be a bottom-up approach, that slowly but surely, with kind of the cultural shift towards a greater understanding of, you know, the grey areas in medicine, and that appreciation that the black and white risk assessments don't work, that an integrated risk assessment is actually more informative and more helpful for everyone involved, that sense will essentially diffuse its way up through a hierarchy, and that systems will shift accordingly. My instinct is that the system itself will be reluctant to shift in the first place. I would love to be wrong. I would love that day, but I wonder if the culture change and the society changes that we're starting to see, that many of us have touched on, will have the greatest impact of all.
I mean, talking of integration, at my point in my training at medical school, I'm currently working out how to present back histories, and I've sort of throughout this whole thing gone through and like tried just to summarize this entire conversation in like a sort of history sort of thing, and I sort of went through and kind of came up with like a few words just to sort of how I felt this conversation went about like the language of suicide and my perspective on it. And I wonder what your opinion on it would be, like as a closing sort of remark sort of thing. And I said that, you know, the language of suicide is just that, it's a language in itself. Like suicidal patients, the more they present, they begin to learn the secret language that the medical field has surrounding suicide risk, risk assessment, screening questions, and they can almost manipulate it to suit the fact that they might want to not lose their freedom, or to have lose their custody of their children, or to not be sectioned. And we need to break free of this language and separate it from past stigmatization to offer a new lease of kindness, openness, honesty, and communication with the patient. And this would allow patients to break free from the fear of loss, freedom, and instead trust professionals to work with them to reduce their risk level, which is what Mary said about owning your own risk, and have their best interests at heart as patients, and not the clinician's fear of repercussions should they tick the wrong box in algorithm. And I think that's what I took away from this, is that it's centered around the patient. And yeah, I think that's what I thought. So that's my presentation, the history done.
Busy. That was really helpful. I was going to ask for, we've gone over time, but it's been so interesting, but I was going to ask for kind of any closing thoughts that everyone may have. And I think you started us off in a brilliant way with closing thoughts there, but maybe if people would like to say kind of one more thing, what's the one more thing that you would say as part of this conversation?
I just wanted to say thank you really to everyone, especially to Chloe, for organising this and bringing us all together, because I think it's been a really exciting, rich and diverse discussion really. And so yeah, that's my closing remark really. Just thank you everyone.
Thank you, Becky.
I think my closing remark is exactly the same really, just to thank everyone on the call, to thank you, Tom, for helping us and guiding us through this conversation so well, but also to thank the people who will be watching it and listening to it, for a willingness to open their minds to this area that is contentious, because it is not the safe path. It is a slightly more perilous path to do something that seems to be slightly at variance with what is expected of one is always difficult. So to thank people for watching it too.
And to hold hope that times will change and that approaches will change. And just as we try to, as best as we're able, hold hope for our patients, that we can do that for the system too.
Yeah, I think again, thank you to everybody. I've really loved doing this. It's inspiring to speak at such length with such an interesting group of people. And to anybody watching this, and particularly to people earlier on in their career, students, trainees, you know, other health professionals, you know, if you want to take something forward, my advice is challenge convention and be nice to people. I think that's the summary of this session. I think that's what works, and keep doing it. And don't be afraid to challenge convention.
That's a great advice for life, I think. Challenge convention and be nice to people. Just my only thing to close is, again, well, to thank everyone, as everyone else has thanked everyone. But I also was thinking at various moments throughout the conversation that one of the things that kind of gives me some hope in change is people talking like this. And there were times when I felt that, wow, I really would hope that all medical students and consultants and chief executives and directors of service and team managers could listen to some of this, because you couldn't help but be moved to think that maybe you could do something a little bit differently, or to question whether you could do something a little bit differently. So I hope that the people who are listening have taken that away from this as well. And thank you to Becky, Izzy, Kiara, Mary and Chloe for such a fascinating conversation. And thank you for, well, I'm grateful that I'm part of it. So thank you, everyone. Goodbye.
Thank you, Tom.
And to Emily too, who's easy to forget because she's hiding at the bottom of our screens, but particularly thank you to Emily for all her efforts to make this possible.